What do you do when someone's heart stops? What do you do? Going to be talking about that today. What do you do in the hospital? What do you do when you're out there? When you're around someone and their heart just stops? So I'm ICU Doctor from TikTok, and this is my new podcast. This is episode 2. I'll be talking about that today. I think the overall structure of this podcast, I'll talk about something medical, usually critical care or anesthesiology, because I do both of those things. And then I'll probably address some sort of social issue that's been in my mind. And then I'll answer questions from TikTok or from people that send to my email, the mailbag here. And then maybe we can finish out talking about books, book recommendations, stuff like that. This is a free-flowing podcast. We can talk about anything. So please just tell me what you want to talk about, and we will do that. So let's go. There is a code blue, which is in the United States, that's what we call when someone has cardiac arrest rate arrest. Usually you go in the room and someone's doing chest compressions. Most code blues, when I hear them overhead or on my pager and you go there, they're not real code blues. And what I mean by that is usually someone just wanted more people to be there, and we're not quite doing chest compressions, but maybe we're close. And that's fine when people call code blues for that. So when I come into the room, I always look to see if someone is doing chest compressions. So I went to a patient's room once from a code blue, and I went in, and the patient was on the floor, and he was talking, and I was like, oh, so this is not a real code blue. This is not a big deal. Something else is going on. This patient isn't in cardiac arrest. Maybe they need some other medical care, but they don't need an ICU doctor like me to be there. But then, and I looked at the guy's heart rhythm, and he had a normal rhythm on his EKG that was up. But then it flatlined, and he stopped talking, and he went completely flat. And then the nurse got on the chest and started doing chest compressions again. So I was like, oh, okay, no, this is legit. Something bad is going on. And the nurse was like, yeah, he coded, and I did this, and I'm doing it again. So a couple thumps in the chest, and the guy gets back up, and he's like, oh, ugh, and he's fine. And then I'm watching his heart rhythm, and then it flatlines again. So I know what's going on here. I work in the cardiac ICU, and this guy's on the floor, meaning he's not in the ICU. He's now in a more stable, medical ward, surgical ward. And I know that he's in heart block. But I want to back it up. I'll get back to that. I want to back it up. So if you're a medical provider, whether you're a nurse or you're a fellow or a resident or a medical student, I want to just talk about how to approach a code blue. What do you do when you show up at the door? So ask yourself, when you're at a code and you show up and you're standing there, say there's chest compressions going on, and you start seeing other people show up, what is the first thing that they do? Think about it for a moment. They usually ask questions. They're usually like, oh, whose patient is this? Where's the primary team that's taking care of? What happened? That's usually what people do when they show up. And what you get is a clogged hallway, a clogged doorway of people one after another showing up asking questions. And it's totally understandable. When you're in a situation like this where someone's in cardiac arrest, you want to gain control as quickly as possible. And there's this unsettling feeling as you come in, you're out of control, what's going on? And information helps you feel more in control. So that's why people usually do that. I want to suggest a little bit different approach. So years ago, my approach is different. When there's a code blue, I come into the room and I say nothing. My goal is to say nothing. So I work at a major academic hospital. So usually there's a resident or a fellow that's running the code already, or they're there to run the code. If there's not someone there to run the code, obviously I will run the code as the ICU attending, and I will speak up. But if the code is already running, if people are doing chest compressions, I'm silent. I come into the room and I look at the patient. That's the first thing I do. I just look at what is happening to the patient. Oh, they're doing chest compressions. Oh, do they have a breathing tube in? No, they don't. Oh, someone's bagging, meaning they don't have a breathing tube in, but they have a mask over their mouth and nose, and they're giving them breaths. How well is that going on? Are they bagging appropriately? Is the oxygen turned on from the wall? I look at all these things, gather information, and then I look up and to see if there are any vitals, like the blood pressure, the heart rate, the rhythm, the pulse ox. Sometimes there aren't vitals in a code blue. Sometimes there's not, because you can't get vitals because you're doing chest compressions. So I look to see if there are vitals. And then I come around the bed and I listen to the patient's lungs. I do a physical exam. And it's not rocket science. I'm listening, are there breath sounds? Are we moving air? Are they wheezy? Are there bilateral breath sounds? Are there breath sounds on the left, and are they on the right? I do those things. And then I take over the code if I need to, start running it, be the leader of that code if I have to. And then information about the patient starts to percolate through their past medical history. Oh, they had this surgery. Oh, we have this and that. That reaches me. And then after a few minutes, if I really need to know other information, then I will ask someone to read the chart or stuff like that. But my approach is to be silent, to be calm, to gather information with my senses, not speak, to wrap my mind around what's going on to begin with. And then the next thing I do is make sure that the documenter, the person that is taking notes about medications, that is giving times, to assign that task, because that person is the metronome of the code blue. They are making sure, they are calling out, they're saying, hey, it's been 2 minutes, you need to do a pulse check. You gave epinephrine, it's due. I make sure that person is assigned right away, and I point to whoever it is. I'm like, who is it? Is it you? Is it you? It's obviously it's best to use names, direct names, but in a big academic center, you don't know everybody's names. So you do have to point at people and say, I mean, that's just being practical. So I make sure that the metronome is going, and then off we're running with the code blue. So back to my patient that I was talking about. So I knew he was in heart block. The reason I knew he was in heart block is because I know what kind of patient he is. He's a cardiac patient. He had a cardiac surgery probably 8-9 days ago. He went to the ICU, and now he's in the surgical ward. And I was like, this guy has heart block, because when you have cardiac surgery, oftentimes you get inflammation around the electrical conduction system of your heart. And that inflammation can lead to scarring, and that scarring can affect the conduction system. Heart block is where the electrical system at the top of the heart can't communicate with the bottom of the heart, and you basically go into cardiac arrest. And he was doing that over and over and over again. So context is tremendous, right? I knew this. I wouldn't suspect that he was in heart block if it was a random patient on a different medical ward or on the street. I wouldn't be like, oh, it's heart block. But context matters and experience matters. So that you really bring your experience to a patient in a code blue, and that can really give you a leg up. So we are doing chest compressions, getting him back. He wakes up. He fights us off. He's like, what's going on? And then he goes into cardiac arrest over and over again. So much, we can't even get him off the floor. This man is on the floor, literally the floor. We finally were able to get him into bed. We're constantly doing chest compressions. And he would have had epicardial pacing wires that were placed surgically, but they were to pace his heart, with electricity to pace his heart. But they were pulled earlier that day. So we had no way to pace his heart. Obviously, we had pads on his chest to shock his chest, but we weren't able to get capture. What that means is the electricity wasn't connecting with the muscle of the heart to be able to shock it. So we had to keep going back and chest compressions, finally stable enough to get him into the bed, still doing chest compressions. And then away we go to the ICU. And we're rolling him off. Someone's in the bed doing chest compressions. He wakes up, fights the person off, and we're doing chest compressions over and over and over again. Obviously, this man needs continuous electricity to his heart. What he needs is a pacemaker, and I know that. I know he needs a permanent pacemaker, or what we call a temporary permanent pacemaker. But how do you bridge him? So we were constantly shocking him. And then of course we get to the ICU, and we lost his IV. So he has no IV, and he's in heart block, and he's constantly going into cardiac arrest. And the guy wakes up. He's fully aware of what's going on, and there's no way to avoid this situation. So we obviously work on getting an IV access, and the only option is here at this moment, emergently, we need to put in a central line, and we need to float a pacing wire down into his heart and start pacing his heart. That's the only thing we can do. However, during this time, we were able to get capture through what they're called transcutaneous pads that go on the skin. We were starting to get capture, electrical capture. So finally we're pacing him and keeping him alive without doing chest compressions. But now we have the problem. He has no IV, and he's completely awake and aware and getting shocked. The guy is very understandable the situation. He's like, it's fine, and he's like getting shocked over and over again. Finally, we get an IV. I give him some midazolam and fentanyl to kind of zonk him out, which worked well. And then we put a central line in, and we float the wires down to his heart. Actually, a PA line, a pulmonary artery catheter, or a swan line, and put pacing wires through that, and we get capture, start pacing his heart. And finally, we have a little bit of stability, and then I call EP, electrophysiology, the cardiologist. This is at 1 a.m. or something, and I'm like, you got to come in and place a temporary permanent pacemaker, which they did, and the guy was stable, and he left the ICU the next day. It was great. Every code is a little different. I mean, the algorithm, what you do, how you run it is the same. That's why there's an algorithm. We call the ACLS algorithm. But, where the patient, their medical background, how old they are, Are there family around? Did they have a recent surgery? Is it in the hospital? Is it out by a pharmacy? Did someone fall by the door? Did someone fall in the street? They're all a little different, and you got to be flexible and you got to be adaptable. Rigid thinking can really get you into trouble. One thing that can really happen is anchoring bias. You are there from the beginning and you think it's this thing and it can't be something else, and you just keep going. No, it's this, it's this, it's this. That's anchoring bias. And you can convince everybody else in the room about this anchor, that the anchoring on this bias, on this conclusion or this diagnosis that's incorrect. And sometimes all it takes is someone with fresh eyes to come into the room and be like, wait a minute, it's this is going on. And you're like, oh, duh, of course. And that has nothing to do with even experience, or, I mean, it can, or expertise. Sometimes just being the fresh eyes. I've been the person where I have tunnel vision, I don't know what's going on, and I've also been the person that comes in with the fresh eyes. Everybody plays these different roles, and that's why it's so important to be collaborative and have as many people as possible, and crowdsourcing and having consensus decision making is extremely important. Okay, so what do? Let's say you who are listening right now, you don't have a medical background, and you're at Chuck E. Cheese. Is that even, I don't know if that's the thing anymore. Whatever, you're at Chuck E. Cheese and a stranger next to you collapses. What do you do? I want to step back and say that the panicked mind doesn't function well. We all know this, right? If you are panicked, your cognition goes down the drain. You can't think. I mean, you've ever been to order something at last time you were at Chuck E. Cheese and you wanted to order something, and then you get up and your mind panics and you're like, what was I going to order? And you just kind of freeze. Obviously, that's just like a small example. There's many more examples I can't think of right now. But the panic brain seizes up, and this can happen to anybody. And so when you're out there and someone arrests, what do? Now, of course, there's algorithms, right? And those are helpful. They're useful. Of course, we need them. But I just want to put something in, just put this little nugget into your brain. Call for help and do chest compressions. That's it. Call for help, go up and feel if there's a pulse. Feel it at the neck, at the carotid. That's usually one of the easiest places to feel it. If there is no pulse, and if you don't feel it in like 10 seconds and they're not responsive, do chest compressions. That's it. Just put that in your brain. Go up to them, say, ma'am, how are you? They're unresponsive. They're not responsive. Call for help. Tell someone to call 911, or you call 911 while you're feeling a pulse. If you do not feel a pulse for 10 seconds, you start doing chest compressions. That is what you need to remember. And why do you need to do chest compressions? It's because you are now taking the place of the heart. You are pumping the heart for the patient. You're literally pumping blood to that patient's heart with your chest compressions. If the organs do not get continuous, if they're not bathed in continuous blood flow, that person will die. If their brain is not getting continuous blood flow with at least some oxygen in it, they won't survive. Even if EMS comes later and resuscitates the patient, they will have irreversible brain injury. The human body can't sit there without perfusion. The brain will die, and that patient will die. The chest compressions are key to keep blood circulating through the body. Even if it's junk blood, even if it's full of carbon dioxide and super low in oxygen, it's better than nothing. And you will be shocked that people can survive. Doesn't mean they will, but this is what you need to do. Get on the chest. Get on the chest. Do that. If they don't have a pulse, call for help and get on the chest. What you need to remember is when you're doing chest compressions, you need to allow for complete recoil of the chest compressions. You pump in, you do hand over hand, and your palms are going right into the sternum. You press down and you pull up. You release, you allow that recoil, because that's how the blood fills back up with heart, so that it's primed to pump blood back out. So you must do that. You have to let the chest recoil. If you don't let the chest recoil, you're not circulating blood around the body. Now, when people arrive, you have help, but maybe EMS is not there yet. You do 30 chest compressions for every 2 breaths that you're giving. Maybe there's a kit nearby that someone brought, and they're able to put a mask over, and they're bagging the patient's lungs. You do 30 chest compressions for every 2 breaths. And then when the defibrillator arrives, or it's also called an AED, that should be around, hopefully. You put that on the chest, you turn it on, and you do what that robot voice tells you to do. That's it. Let's keep it simple. Chest compressions within 10 seconds if you don't feel a pulse. Put on that defibrillator. Do what that tells you. Do these things until the patient comes. Until the EMS comes. When in doubt, do chest compressions or that patient will die. Now, getting back to maybe speaking more to medical providers, I want to stress the importance of doing a physical exam. So I told you, when I come to a patient's room, I listen to the patient's lungs. I assess the patient's body. I had a patient who maybe had COVID, maybe didn't. We intubated them recently, like an hour prior. They crashed after getting intubated, and we were just struggling with this patient. Every time we ventilated the patient, their blood pressure would drop. The blood pressure would drop, and then we would put them back on the vent. The blood pressure would come up, but they were super hypoxic. Their oxygenation was terrible. And I was like, something is up. And of course, I had already listened to the lungs and everything. But I listened again. I listened to the left side, and there was no breath sounds on the left side. And the team that was there prior to me, that was working on the patient, they were like, we listened to the breath sounds. And we also we put a camera down there to make sure that the breathing tube was in the right place. Because sometimes if you have a breath sound that's out on one side, it means the breathing tube might be too far. So that was ruled out, and I was like, okay. So I even I put a camera down myself called a bronchoscopy. And I saw that the breathing tube was in the right place. And I was like, all right. So, okay, that's in the right place. But the patient was still crashing. They're in shock. Every time we ventilated the patient, bagged the patient up, ventilated the patient up, blood pressure would drop like a rock. And I was like, why is this patient in shock? Early COVID like this shouldn't be causing shock. It should just be hypoxemic. I'm like, something is wrong. So I went back to the physical exam. I went back to the chest. I listened. There was still not good breath sounds on the left side. It didn't make sense. And then I felt that the belly was kind of distended. It was what we call tympanic, like timpani. Like I could drum on it, and it sounded like air was in there. And I was like, what? I was like, something is up with this patient. And then it just kept going, the cycle over and over again. And then I felt the patient's lung again, and I felt air under the skin on the left side. And I was like, oh my gosh, I know. And because I did that physical exam, I knew exactly what was going on. The patient had a tension pneumothorax, which is a collapsed lung on the left side, where all we're doing is we're pumping air into that collapsed lung on the left side, into that thoracic cavity, and it's shoving the entire heart and all of those vessels to one side, and it's making it so blood can't return to the heart and pump back out. That's called a tension pneumothorax. It is a huge emergency. So as soon as I saw that there was air under there, we put a needle into the patient's chest, in between the ribs, decompressed that air, and the patient immediately did better. Right after that, got out of that shock state. I know I sound like an old geezer talking about physical exam. You must do a physical exam, a basic physical exam, every time you have an emergency to rule out the basic things. It is extremely, extremely important. Okay, let's switch gears here a little bit. I want to talk about the difference between median and average. The reason I want to talk about this is it is so extremely important to understand the difference between these two things to prevent from being manipulated by the media and politicians. It's extremely important. So let's distinguish between average and median. Let's talk about average first. So we know what average is, right? Let's say you have 10 animals of 10 different heights, and you want to know what the average is. You add up all of their heights and you divide it by 10, and that tells you the average. Let's say there's a zoo that only has 2 gophers. That's the zoo. It's 2 gophers, and they're half a foot tall, half a foot. And they advertise, hey, we have animals that are half a foot tall. And you're like, I'm not really that interested in seeing an animal that is half a foot tall. And then a week later, you see an advertisement from the same zoo, and they're like, guess what? We have the average height of our animals is now 7 feet. And you're like, whoa, I want to see what they got. And then you go to the zoo, and there's still just 2 gophers there at half a foot. And you're like, what happened? I thought your animals are now 7 feet. And they're like, oh no, that's the average. We got a giraffe, but it's sick, and so we have it in the back. So what happened here? Average skews towards the extreme. So if you take the average of 2 gophers that are half a feet, that's 0.5 foot plus 0.5 foot divided by 2, which is 0.5 feet. So the average of 2 gopher is half a foot. But if you bring in a giraffe that's 20 feet long, tall, so that's half a foot per gopher, 0.5 plus 0.5 plus 20, divide that by 3, the average is now 7. So in an average, extreme values skew the average, and they skew towards the average. So what's the median of these three animals? What is the definition of median? What is that? The median is the exact middle, where the middle number. It's the middle value. It's where most of the numbered things that you're numbering congregate around. So let's go back to this example. 3 animals. 2 of our gophers that are half a foot tall. The third is a giraffe that's 20 foot tall. The average of these 3 animals' height is 7 feet. The median is half a foot, the exact same height of the gophers. So the median represents reality more than the average does in this instance. Okay, so let's connect this to real life. If a politician says, I have a tax plan that's going to raise the average American household income, you red flags should be blaring in your ears when you hear that. Because what's the pitfall with average? Extreme values skew the average. Extreme values will skew it more towards that extreme, just like the giraffe. So if some politician comes up with a new tax code, a tax plan, and they're like, oh, this new tax code will raise the average American wealth to such and such number, that tax plan likely favors the ultra rich. Because if if something's going to swing the average, it's going to be an extreme value, like raising the wealth on the top 1%, top 0.1%, and that could greatly change the average. But you got to ask, okay, what does it do to the median wealth? And my bet would be it wouldn't budge at all, meaning it doesn't benefit the rest of everybody else. And so this is a very easy way to manipulate what's going on. Now, if all the values are the same, and average is perfectly fine. If all the values congregate around the same kind of number, then that's totally fine. But you need to know what the average is. You need to know what the mode is, which is the value that appears most frequently. And you need to know what the median is to really make a full analysis of what's going on when someone comes with you and they say, hey, my plan, whatever it is going to change the average blank. Okay, red flags are going, and you got to look deeper into this. All right, that's enough of that. I'm going to move on to questions from the people left on TikTok. Again, you can leave questions there on my TikTok at ICU Doctor or my Gmail, which is icudoctorecmo@gmail. First question is from Laura Diane 1 on TikTok, and this person asks what to do to prepare for surgery. So, if you're having surgery, I think it's for one thing, I give you the permission to be nervous. It's not every day that you have surgery. You don't go in an anesthesia and have a surgery. I've actually never had surgery myself. I've never had anesthesia, which is, I know, it's weird. Sometimes I share that fact with patients and it doesn't bring them a whole lot of comfort, which I get. Anyway, I would be a little nervous, and I do this every day. But one thing you need to know is that the most dangerous thing that you've done that day is drive to the hospital. So, and that just shows you how our human brains, how we think, the weight that we put on things. That statistically, the most dangerous thing that you did that day is get in a car. You're more likely to die or be injured in that car than on the operating table. So anesthesia is very safe. We put it statistically like as safe as getting on a plane. So I think the things to talk with your surgeon are, what is informed consent? Do you have informed consent to do the surgery? Have you been informed of what the risks are, what the benefits are, what the alternatives are? Have you agreed to it? Has that all been explained to you? Or have you been coerced into it? Have someone talked you into do it without explaining those things? Because that's what coercion is. If someone does not explain the risks, the benefits, and the alternatives to you, then that could be coercion. So that you should have that consent and that talk with your surgeon in the clinic and also the day before, the day of surgery. And then when you see your anesthesiologist, either it's a MD anesthesiologist or a nurse anesthetist or both, or a resident or a medical student, you should ask what kind of anesthesia you're going to do. Is it going to be a general anesthesia, which is typically has a breathing tube? Is it going to be moderate sedation where you don't have a breathing tube and you're breathing on your own? Are they going to use local anesthetics? Are they going to numb up a limb? Which is called regional anesthesia? What are they going to do? And what are they going to do for pain control? Are they going to give opiates? Are they going to do regional anesthesia, like I just mentioned, like numb up your limb or a finger or whatever the surgery is? Is a spinal surgery an option? Not surgery. Is a spinal anesthetic an option? Is epidural an option? have this discussion about your pain control. Advocate for your pain control. Make sure your pain is being controlled beforehand with maybe some pre-op Tylenol, which can help. What are they going to give you in the operating room, and what are they going to give you after the operating room? And then ask about nausea. Have you had nausea in the past? Do you get motion sickness? Are you at risk for getting nausea? Are you a young woman? Are you a non-smoker? Are you getting a gynecological procedure or an ear procedure? Those things put you at risk for having nausea. And what are they going to do about that? Because there's many, many different plans to help with your nausea. So those are two things, pain and nausea, that the anesthesiologist should be able to take care of, and those are things that you should talk about. And then I want to add that whatever you're worried about, you should bring up. You talk about whatever is on your mind. Do not hold back. If you're worried about having the IV placed, talk about it. Don't feel like you need to be quiet about things. Be as open as possible with your anesthesiologist. If you smoke marijuana every day, tell them that. If you took a benzo that morning, like you popped a Xanax or a Klonopin, tell them that. They don't care, but it is helpful for them to know how to dose things. Be as honest as possible with your anesthesiologist and your surgeon and everybody that asks you medical questions. They cannot criminalize you, and they don't care if you've committed crimes. Just, like doing drugs or things like that. Tell them, do you do methamphetamine? Do you smoke? How much do you smoke? How much do you drink? Really? How much do you drink? Is it half a pack a day, or is it more than that? Be precise. It's important to know these things because the dosing of the anesthetic matters. All right, next question from TikTok is from Leanne Beachgal. This person asks, how do you advocate for a loved one in the ICU, especially during COVID time when there's no visitors allowed? This has been an extremely difficult time with the pandemic. I took care of a lot of COVID patients, ECMO COVID patients, during a time when we had restrictions where no visitors were allowed. How do you advocate for them? Ask questions. Ask a lot of questions. Ask them every day, and ask them to everybody you see. Demand to talk to people. If it's been a while, if it's been a day, and you haven't talked to a physician, demand to talk to them. And when I mean demand, you don't need to be rude. Although you can be rude. That's fine. Be rude. You have the right to be rude. It's fine. But when I say demand, just be like, I haven't talked to a physician in a while. I would like to talk to them. I want to know what's up. And then if you want to know what the labs are, say you have a family member that's a physician or a nurse or something, and they want to know, well, get the information for them. Demand information. It's your right to know them as someone who's taking care of a loved one. It is absolutely your right. Know what the hours are that you can be there, and then being respectful, of course, is good. But again, you don't have to have this nice etiquette. Be someone that's like putting the thumb in the back of your care team and kind of demanding a little bit more, because we're all human, and all humans can be lazy and kind of drag their feet on stuff. And if they know there's a family member that's like, hey, what about this? What about this? It makes us put a kick in our step. So I really recommend that you just don't assume that everybody knows what's going on with your loved one. Don't assume it. Assume the opposite. Assume that your loved one absolutely needs you there advocating for them, because guess what? They do. All right, so I want to discuss a book kind of that has to do with a little bit that we're talking about today. And this is a pretty famous book. You may have heard of it. It's called Thinking Fast and Slow by Daniel Khaneman. This was written in 2011. This guy is a brilliant psychologist. And this book is about recognizing bias in how you think. One of the themes of the book is all you see is not all that there is. The book is brilliant. He's highly specialized, and it gives him free rein to discuss how the human brain thinks and all the cognitive errors that clutter not only our thought processes, but the very way in which we perceive reality. He provides a mental framework for the entire book, splitting the mind into two working models, System 1 and System 2. That's a theme throughout the whole book. System 1 in your brain is the knee-jerk response we have to the world and its stimulus, the part that makes snap judgments, quick decisions based on just immediate information. Step 2 is slow thinking, the deliberate part of the brain, the analysis, and that reserves judgment. And that's major. There's a major problem with these two processes. System 2 is inherently lazy to activate, and it takes quite a bit to even turn on System 2. So we usually like to lean on System 1, the knee-jerk response. And with that framework in place, the author explores this just a treasure trove of biased thinking. Ego depletion and self-restraint require energy. And we don't turn on System 2 unless we're forced to, or we've trained our minds to activate this system. actions and emotions that we experience are primed by immediate events and even trivial objects that are in our environment, like a glass of water. There's a ton of data and literature presented about the priming of the human mind with something like money. He talks about something called cognitive ease. That's finding the pathway, the mental pathway of the least mental resistance. That's, arriving at conclusions which are the mental equivalent of sitting on the couch and continuing to watch TV. The human brain is engineered to see causality everywhere, even when causality does not exist. This one fact alone accounts for how easily the human mind can be manipulated by the media and politicians. Humans are terrible at teasing out correlation, causality, and probabilistic causality. He talks about something called the halo effect, which primes our brains to believe someone or something that we already have a favorable opinion about for arbitrary reasons. And then there's sample size. That's an enormous source of cognitive error. Yeah, people can read studies in medical literature, and then they can come to very ridiculous conclusions. As an ICU doctor myself, I've seen this especially during the pandemic. People are unbelievably bad at understanding sample sizes, retrospective data, propensity score matching, randomized controlled trials, and meta-analyses. The non-medical mind cannot make heads or tails of actual data, and they just go about cherry-picking in vitro or animal studies to support their false political biases. I've seen it a billion times. We get a discussion about the anchoring effect, and that's huge. You pull a number out of thin air, and suddenly everyone will anchor to that as if it's suddenly the valid number. Random anchoring numbers influence everyone from judges to real estate agents. Availability bias dictates that we make decisions assuming that the information that we have available is the only information that exists. Everyone ignores the base rate, meaning what is typical for a given set of numbers, and replaces it with a heuristic stereotype. If you suddenly discover something amazing, it's likely a problem with your method and ignoring the usual base rate. I see this mistake in medicine all the time. Outliers are extremely rare and should always be treated with skepticism. People mistake causation for what is only regression back to the mean. This is an incredibly important principle. Is something causing something, or is it just regression back to the mean? For example, let's take every junior high student on a certain day who did poorly on all exams administered that day. So you take all those junior high students, everybody that took an exam that day, and you take all the ones that did poorly on all the exams. You then put all of those ones that had poor performance in a remedial program to help with studying and test taking. We then see how they do on exams afterwards, and lo and behold, the exam performance has improved. This does not mean that the remedial program worked. It simply may be that some of those students did poorly one day and simply did better the next day, because numbers sets will always regress back to the mean or the basal rate. This confusion happens all the time. The idea of skill in something like the stock market is a complete illusion. Experts in all fields are actually worse than a coin toss at predicting trends. Why? The hubris of the expert heuristic. They are overconfident in their abilities and fail to understand that forecasting has more to do with happenstance and random chance than skill. There's so much more to talk about with this book: risk aversions, risk-seeking, endowment bias, prospect bias, but I'll leave that for you if you want to read this book. It's a must-read. Pick this book up. It is a staggering work of brilliance that sheds much-needed light into the irrational working of the human mind. All right, well, thanks for listening. I think I'll call it a day on this podcast. Please let me know what you would like me to do different. I'm not really a podcaster. I don't really know how this works that much. So you can email me at icudrecmo@gmail.com. icudrecmo, ECMO @gmail.com. My TikTok handle is ICUDoctor. My Instagram handle is ICUDoctorTikTok. You can message me or whatever, ask me questions on any of those platforms. And I'll just keep going with this thing and these little random free times that I have. Let me know what you like, what you don't like, and please rate and review the podcast and share it with people. Seems like something that people say at the end of a podcast, so I'll just say that now. All right, thanks for listening. Bye.